Hello everyone, today I'm going to present about robotic assisted bronchoscopy. So there are two types of lung nodule biopsy. The first type is transthoracic biopsy and the second type is transbronchial biopsy. Each type of biopsy has its own strengths and weaknesses. So the transthoracic biopsy is frequently performed by interventional radiology. It has very good strength because the diagnostic yield has been proven to be in the 90 to 95% of the time, and then usually no general anesthesia required. The weakness, however, is that if it is proven to be malignancy on the biopsy, the patient would need to go back for another bronchoscopy and staging. And then the second type of weakness is that it has a relatively higher complication rate in terms of the lung complication, such as pneumothorax and bleeding, which can happen to 5 to 10% of the cases. The second type of biopsy I would like to talk about is the transbronchial biopsy. So since the invention of the flexible bronchoscope back in the 50s and 60s, the transbronchial biopsy has been used to biopsy lung nodule as well. However, the diagnostic yield has been very varied. It ranges from 75 to 91% of the time depending on the equipment, and I'm gonna go back to this in a little bit. The benefit of this type of biopsy is that it can combine the staging EBUS in just one procedure, so the patient goes home with the malignancy diagnosis and staging at the same time with a relatively low complication rate of only 1 to 2% of the time. And I'm talking about lung complication rates such as pneumothorax, lung collapse, or bleeding. So bronchoscopy is well known for its ability to biopsy central lesion. But we have to talk about the weakness because the diagnostic yield for any peripheral lesion can be as low as 50 to 70% of the time, but it really depends on the type of the bronchoscopy that the operator uses, because it can be also up to 91% of the time as well, depends on the nodule location as well. And also, in order for the patient to get kind of long navigational bronchoscopy, general anesthesia usually is required, and then the risk of general anesthesia has to be discussed with the patient as well. So this topic today I'm going to focus about is transbronchial biopsy of peripheral lung nodule. And we talk about there is such a variation in diagnostic yield for transbronchial biopsy, and why is that? So biopsy of the lung is not simple, okay? Because first of all, it's a dynamic structure, and second of all, it's because in order to go to the nodule, we just like going through tunnel, right? Just imagine that the nodule is a little lotus in the pond right here. In order for the frog to go to the pond, it has to go through the maze. It has to go through different tunnels, and that have to be the very correct pathway to be taken. And there's no light inside the lung at all, and so it's hard to go to the nodule, right? So in order to achieve that purpose, virtual bronchoscopy to create the pathway, the guidance to the nodule has to be made, right? And then there should be technology to track the tip of the nodule, track the tip of the needle, and also there should be technology for airway segmentations as well. And once we think that we get there, right, we get to the frog, so how can we determine that this is the nodule that we have to biopsy, right? So there comes the technology such as radio EBUS to confirm the nodule, as well as CT cone beam as well to kind of confirm that the needle is in the nodule. So there are a lot of technology to be involved. Another challenge that we have to know is that the airway inside the lung is not large, right? As you can see here in the picture, in the outer third of the lung, the airway can be as small as 1.5, 1.9 millimeters. And so in order for the bronchoscope to get to the nodule, it has to be a thinner bronchoscope because normally the flexible bronchoscope, the outer diameter is up to 6 millimeters, and so it's harder for the larger bronchoscope to reach all the way to the peripheral lung. This is the historic timeline of peripheral bronchoscopy. from before 2010 up to now. So as you can see, before 2010, there wasn't a lot of technology in the field of bronchoscopy. Basically, they just biopsy the nodule with flexible bronchoscopy and plus and minus radial EBUS. And the diagnostic yield of this technology really depends on the size of the nodule as well as whether it's close to the airway or not. And then the diagnostic yield is proven to be about 57% based on the acquired study. The period from 2010 to 2020 observed multiple developments of peripheral bronchoscopy, and most well-known technology is electromagnetic bronchoscopy, which is still extensively used nowadays because it's very good. It basically uses electromagnetic navigation to track the tip of the locatable guide inside the patient's chest, and then it's correlate it with the virtual pathway that has been drawn out based on the prior CT scan of the patient. And then this technology has a diagnostic yield of peripheral nodule of up to 75% of the time. Other technologies that are available is the electromagnetic bronchoscopy in combination with fluoroscopy tomosynthesis to kind of like confirm the location of the nodule intraoperatively. It's the diagnostic yield of this technology can be up to 74.9% based on the study by Dr. Abu Dara in 2019. And then there comes also other imaging technologies such as lung vision as well. And then there comes the development of the ultra-thin bronchoscope, which is proven to have a higher diagnostic yield compared to regular flexible bronchoscopy with radial EBUS. The period from 2020 to 2022 has very advanced technology developments, most notably in the field of robotic bronchoscopy. There are two main players in this field. One is the ION by Intuit, and then the second is the MONARCH robotic bronchoscopy by Auris. There have been a few studies that show the efficacy of these two robotic systems with the study from Memorial Sloan Kettering that proved the diagnostic yield of this shape sensing robotic bronchoscopy from 81 to 95% of the time. And then in the benefit study, which I'm going to talk a little bit, diagnostic yield can be up to 74% of the time. 2022 and beyond, it's going to be an exciting period of time where there will be a lot more studies in the field of peripheral bronchoscopy will be published. And I'm going to talk to you more in a little bit, okay? Now I'm going to talk to you more about robotic bronchoscopy, but first of all, I'm going to talk to you more about how we can achieve a successful navigational bronchoscopy. It has to meet four main categories, okay? First is the ability of the bronchoscope to reach, to stay in shape. Second is the ability of the software to find a correct pathway. And third would be the ability of the system to eliminate city to body divergence. And fourth would be the tools that used with the bronchoscope in order to get the tissue sample. So robotic assisted bronchoscopy is the state-of-the-art system for peripheral bronchoscopy that can achieve the category number 1, reach, precision, and stability. And why is that? So there are two main players of the robotic bronchoscopy. The first system I'm going to talk about the shape sensing robotic assisted bronchoscopy. And as you can see here, the bronchoscope has a size of 3.6 millimeter, which is almost close to the size of the very thin bronchoscope nowadays. And so it can reach to very further out, up to 9th generation airway inside the lung. And then the ability of it to stay in shape is amazing. Basically, once the scope is flexed, it stays in shape regardless of how you biopsy it. It would just stay in shape, and then it would not miss the nodule because of that. So that would be stability. The catheter is also can fully articulate to up to 180 degree in all direction, and then even the needle of this system can also be flexed easily as well, and so the catheter would not change the angle or stability when the needle is advanced. So what is shape sensing technology? This technology has been available in the past decade, and it has been applied to multiple fields of medicine. Basically, this technology creates optical fiber, and this optical fiber can basically it can sense and know the location of itself. It can reconstruct its own angulation angles as well as location on the 3D diaphragm, as shown on the right hand side of the picture right here. And the robotic bronchoscopy that uses this technology has the shape sensing fiber all along the catheter. And so basically, once we advance the catheter inside the lung, it can know exactly where the tip of the catheter is on the 3D images of the lung virtually. This is an example of how the navigation looks like on the screen when shape sensing robotic assisted bronchoscopy is being done. The upper screen shows the pathway to the nodule, which is marked as blue here. The lower screen shows how the airway looks like under the vision probe when it's still inside, and then it has the incorporated or integrated EBUS screen as well on the left hand side, and the right hand side fluoroscopy screen. Here's the initial study on robotic bronchoscopy modality compared to other type of peripheral bronchoscopy. This is a study on cadaver, and it only has 60 procedures total, so just initial study, okay? So they compare ultra-thin bronchoscope with radio EBUS, with electromagnetic navigational bronchoscopy, and then with shape-sensing robotic bronchoscopy. And as you can see here on the right-hand side, the percentage of identifiable needle in the target is up to 75% or more in the robotic bronchoscopy group compared to just above 40% for the electromagnetic navigation, and then only 20% for the thin bronchoscope with radio EBUS. And I have to stress again, this is the study only on cadaver where there is no dynamic ventilation at all. So sometimes it cannot be applied to the real case scenario. Moving on to human study. This is the so far the largest prospective studies on about 130 nodules published in 2021 as Memorial Sloan Kettering Cancer Center. In this study, the authors included 130 nodules with a malignancy rate of only about 57%. The nodules, most of the nodules are less than 2 centimeter with the eccentric view of 47%, and they use shape sensing technology with fluoroscopy. And as you can see here in this chart right here, the nodules which are from 2 to 3 centimeter has a fairly high diagnostic yield of up to 93% of the time. However, if the nodule is less than that, from 1 to 2 centimeter, diagnostic yield drop down significantly to 70%. One thing that I have to talk to you about is that the strength of this study is that they use a very strict diagnostic yield in which they have to observe all the quote-unquote benign or granuloma, chronic inflammation finding on pathology up to 1 year to determine that this is really benign. And the loss of follow-up rate is low in this kind of prospective study. And then the second thing is that although the diagnostic yield for 1 to 2 centimeter nodules is only 70%, this have to be noted that they only do the study with fluoroscopy, so they haven't taken into account the use of cone beam CT scan yet for those smaller lung nodules. And then the ability of the robotic bronchoscopy to reach the lesion is 97% of the time. So navigation is successful in up to 97% of the time. And almost 40% of the nodules are in the outer 1/3 of the lung. So the reach of this kind of system is definitely there. The second robotic bronchoscopy system is called the MONARCH system, as you can see on the left side picture. In this system, the bronchoscopist has the hand controller to control the robotic arms. The two robotic arms attached to the console, and this robotic arm will control the catheter and the bronchoscope. And then there will be a separate tower with the monitor. There is also an electromagnetic field generator, which is not shown in this picture. This robotic system uses electromagnetic navigation. And secondly, the bronchoscope consists of the outer sheath, which is 6 millimeter, and then the second component is the inner bronchoscope, which is 4.2 millimeter. These two components can be linked and move simultaneously in the airway, or can be unlinked when it reaches smaller segment the airway, and it can provide you all the camera view at all time when you perform the biopsy. The operator stands on the side of the patient, and then the robotic console with robotic arms are usually at the top of the patient's bed. Here's how the typical room setup can look like with the cart and tower fluoroscopy bed, the robot console with the robotic arms, and regular bronchoscopy consoles with monitors and screens. In this picture, I didn't show the electromagnetic field generator, but it technically would be on the patient side when the patient is on the bed. The first cadaver studies for this robotic system were published around 2018. So rich and access studies proved that this robotic system were able to reach further inside the lung compared to the thin bronchoscope because it has a lot more articulation. The access study proved that 94% of the targets with an average size of 20.4 were reached with the needle. Moving on to more evidence. So BENEFIT is the first pilot and feasibility study multi-center to demonstrate the efficacy and diagnostic yield of this robotic bronchoscopy in peripheral pulmonary lesions. This study consisted of 55 patients with the median lesion size of only about 23 millimeter. As you can see on the right side panel right here, most of the lesions were eccentric with radio EBUS view. So just so you know, for radio EBUS eccentric view lesions, if you just use radio EBUS and bronchoscopy, the diagnostic yield of this is not very high. Okay, it's only like 40%, 30% of the time. However, in this study, they proved that the diagnostic yield of this robotic system was 74% of the time, and the bronchoscope was able to be advanced up to 5.5 generation airway, and there was 97% of the time lesion localization using virtual bronchoscopy was achieved. There will be more and more evidences coming out in the next coming years. There's really an ongoing prospective multi-center study currently enrolling patients. So far, they have already 400 patients. The study started from University of Chicago with 7 other centers around the United States. So hopefully we would have some more information soon as far as the efficacy, further safety information regarding this system. I'd like to spend a minute to discuss about the comparison between these two systems, the electromagnetic bronchoscopy system and the shift sensing robotic bronchoscopy system. So there are fundamental differences are the technology that they use. So the MONARCH system use electromagnetic navigation, and the ION system use shape sensing and fiber optic shape sensor navigation. So technically, you have to be very careful with the patient who have pacemaker or defibrillators and other metal devices inside them using the electromagnetic navigation system. The electromagnetic robotic bronchoscopy system has the benefits of having the bronchoscope view all the time with every single biopsy, so you can adjust the catheter to sit on the walls or different walls inside the bronchus, and then you can also suction at the same time if you need to. The second difference is about the bronchoscope. The MONARCH, the inner bronchoscope, is about 4.2 millimeter, and the ION, the outer diameter of the catheter, is 3.5 millimeter. Whether or not difference would make any difference in regard to further advancing into the airway. There's no data for direct comparison for this just yet, but based on my personal experience, the MONARCH and the ION both can reach to very peripheral airway, and then we're able to get to very close to the pleura with both systems. One thing that is worth noticed about is that if you plan to combine cone beam CT scan with electromagnetic navigational bronchoscopy, you have to be mindful about the distance between the field generator to the metal part of the CT cone beam. So far, there have been no data to see if there's a big interference with the cone beam CT scan and the field generator, but based on my personal experience, the virtual target can change the location for a few millimeters to up to a centimeter or 2 centimeter, depending on the location of your field generator and the cone beam CT scan. So technically, during the navigational phase, I tried to keep the cone beam CT scan. I use the mobile cone beam CT scan, and I keep it away at least about 3 feet. Here are a few examples of lung nodules in some challenging positions that biopsied successfully by robotic bronchoscopy. Case number 1, this is the nodule that's very close to the pleura and the pericardium. This location can be fairly challenging even for the transthoracic biopsy, but we were able to biopsy it, and this turned out to be granulomatous inflammation. Second example is nodule very close to the diaphragm, which can be easily covered by any atelectasis in the exploratory phase. We were able to biopsy this using robotic bronchoscopy, using high PEEP, high tidal ventilation setting. And this turned out to be amyloidosis. Third example is the nodule that actually the lymph node station 5. We were able to turn the bronchoscope more to the center, and we were able to get into the nodule or the lymph node. And this turned out to be lymphoma. The next example is an apical ground glass nodule, which is only 0.75 centimeter, and as you know, this nodule will not show on the radar EBUS, but we were able to get a needle in this nodule using robotic bronchoscopy with CT cone beam confirmation. And the result of this nodule is actually ovarian cancer metastasis. The last example is the nodule that's very close to the pericardium as well. It's a fairly large size, but this location would make it impossible for transthoracic biopsy. And we were able to get the needle close to go into the lesion. And this turned out to be adenocarcinoma consistent with lung origin. So the question about robotic transbronchial biopsy and CT-guided transthoracic biopsy, which one is more favorable and offer more benefit to the patients? There's a recent retrospective study coming out from Mayo Clinic comparing these two technology. There were 225 patients total, And the diagnostic yield between robotic bronchoscopy and transthoracic biopsy were actually comparable, of about 88% diagnostic yield. However, the complication rate of the transthoracic biopsy is actually higher compared to the robotic assisted bronchoscopy group. However, no good data have come out regarding this question. In short, a robotic bronchoscopy is a very safe and effective method to biopsy peripheral lung nodule with a very good benefit of combining staging EBUS to the procedure as well, in order to treat the patient appropriately. However, one drawback that we have to be careful about is that robotic bronchoscopy requires general anesthesia. So before this consideration of robotic bronchoscopy, we have to take into consideration of whether the patient is a surgical candidacy, whether the patients have good cardiac performance in order to tolerate general anesthesia for at least 45 minutes to an hour, and high volume ventilation. Thank you very much for your attention. Please let me know below if you have any question. Again, my name is Ann Ho. I'm the interventional pulmonologist.